Welcome to Reimagining Healthcare, the show where we take a hard look at the future of Canadian healthcare by featuring inspiring doctors and leaders who are helping shaping it. In today's episode, we'll be joined by Dr. Sienna Bourdon from Shoreline Medical. Dr. Bourdon, welcome.
Thank you. Happy to be here.
Same here. So you've been part of Shoreline Medical, which is widely recognized in BC for its role in primary care reform and its nonprofit model. You've been there since the beginning, and I would love to start by understanding how this all began and how did you first get involved in building Shoreline Medical?
Sure. Yeah. So I wasn't one of the sort of founding physicians, but I was there from the beginning of the conversations in my role as a local family physician, as well as the hospital lead for family medicine at our small community hospital. And then I later joined when Shoreline opened the second clinic.
Awesome. And what problem were you trying to solve at that time?
So it was twofold, and the problem was multiple family physicians were signaling that they were going to be retiring from our community, which was going to leave a big gap in the hospital because a lot of them followed their own inpatients at that time, as well as a gap in community for family practice. And at the same time, the family physicians that were graduating and joining or wanting to join family practice clinics or communities didn't want to start their own clinic. They didn't want to run their own business. They wanted to have the flexibility to be able to work in a variety of settings, including inpatient care, palliative care, maternity care, and community. So that was the problem we were trying to solve. And it was a collaborative effort with the Division of Family Practice in our community, which got some pilot funding to get a working group together, local physicians, and also the hospital foundation at that time.
And why was the nonprofit model chosen? And what problem did that structure help to address?
Yeah, so I think the recognition that new grads were in a lot of debt and didn't necessarily want to buy into a practice. Physicians couldn't even give away their practices at that time because new grads weren't buying into practices, and they didn't have a bunch of capital to be able to build clinics. And the gap in our community at that time was going to require dozens and dozens of family physicians to be recruited to our community. So recognizing that we needed a couple big primary care centers, and it just wasn't going to happen to ask new grads to put in the money for the capital to do that. So the hospital foundation at the time agreed to be the main funding partner, recognizing the vision was going to be recruiting family physicians to the community who would also support inpatient care and keep the hospital alive. So the foundation agreed to be the main funding partner to put up the capital funding to build these two big, beautiful clinics, with the idea that if we build it, they will come. And that was actually the case. So luckily the foundation was very supportive of that and allowed us to do it. And in order for the foundation to be able to contribute, we had to be a charitable organization.
Awesome. And do you think
that's really interesting. I have also a question about this. So the non-for-profit organization that found at the beginning, they are involved in the beginning, and I understand how. And during the time after the funding part, how are they still involved? Like, what's the dynamic with the clinic and the hospital after that?
Yeah, so for the first few years, it was a very collaborative dynamic. They supported capital costs, like I said, so initially the big clinic in Sydney, and then later the Brentwood Bay Clinic, which also required some significant capital investment. So Foundation donated over $3 million altogether in some of those capital improvements. And then some ongoing contribution for things like ongoing growth, recruitment, retention, our youth clinic, which is funded entirely almost, the operations from donations. In the last few years, the foundation has refocused its priorities, and last year and this year we have become independent in our fundraising efforts in order to continue to fundraise for the part of our budget that requires external funding outside of normal clinic operations.
Yeah. And today, Shoreline Medical is like relatively is big clinic compared to other clinics in BC. When you joined, was it a small group or it was big since the beginning?
No, it started with 5 physicians and quickly grew over the first 5 years to 25. And then we've had some turnover with retirements and recruitment. So we're still at 25. We've got 23 family physicians, 2 nurse practitioners, as well as other allied health. So this Sydney clinic was the original. And then when I joined, Brentwood Bay Clinic came on board. So I moved another clinic that I owned and operated and joined Shoreline as the second clinic.
And was there a specific moment when you realized this clinic could become something truly different?
I think it was a moment, but certainly quite quickly in the first couple of years, seeing how new grads were coming to our community. So the theory of if you build it, they will come, we actually saw it in real time. Like quickly new grads were coming to the community, signing up. They wanted that combination of hospital work and outpatient. They wanted the flexibility. They wanted the sort of turnkey model where they could come and do their work, focus on being a family doctor and not have to worry about all the running the business.
Thank you. And Dr. Bourdon, I'm curious, how do you define success at Shoreline Medical? Are there specific metrics that you track, whether it's clinical, operational, or cultural? Also, are you following a specific organizational framework?
Yeah. So, I mean, at Shoreline, we would define success as meeting the needs of the community. We're a very grassroots, community-led organization. So, meeting the needs of our community is a big part of defining our success. And I think we strive to protect the care that we're providing now while planning for the future and what's going to be needed next. There's a lot of metrics that we track. We track attachment, we track access, we track team-based care, integration, participation in our patient care network. Wellness of our team is also something that we track. We're very focused on people-centered care, and that includes the people that are providing the care. So we also track things like the admin burden to our providers as well.
Awesome. Interesting. Do you have some examples of these numbers? Like, so we know what is your success at Shoreline Medical. Like, what numbers make you say, yeah, it's going well in terms of access, in terms of team wellness? How do you measure that?
So for access, we use EMR metrics. We like to have appointments available within the same day or next day for access. And if that's not happening, then we work on that. And I did a big quality improvement project on that a couple of years ago. And then attachment's a tricky one. We do set targets, and our big blue sky goal is to have everybody on the peninsula have attachment, but also we need to balance that with access, and we need to balance that with projecting retirements and preventing detachment. So we use a lot of EMR metrics, and for team wellness, our HR department typically does surveys, and through our division, we have access to the well-being index metrics that they're using as well.
Awesome. And I'd like to know more in a financial way. So financial viability, where does it fit into this picture? Does it serve as a metric? Is it an ongoing consideration or something else entirely?
Yeah, so financial sustainability and stability of the organization is definitely a metric and part of our strategic plan. The accountability responsibility falls on the board. So I kind of skipped over the organizational structure a little bit, but so I'll go into that now. So we have a board of directors, and I think it's a true governance board. Our board focuses on strategy and focuses on financial stability and viability. So our executive director reports directly to the board at that governance level. And then our executive director works with our operations team. So we have an operations director that oversees both clinics in terms of operational workflows and processes, and then clinic managers and medical directors at each site that focus on the operational side of things and executing the strategy, basically. So the finances, executive director is accountable to the board, and the finances are split into two broad buckets. We have the financial piece around the normal clinic operating expenses of the primary care clinics. And the normal clinic operating expenses are funded out of physician overhead, just like they would be in any other clinic. We're not allowed to use donations to fund typical operating expense, which makes sense. So physicians all pay market overhead, and it's up to the operations team to make sure that we're managing and balancing our budget for the operations of the clinic. And then we have society level costs that would go into things like our youth clinic, our maternity program, our hospital inpatient care, recruitment, retention, growth, those kind of things. And that's where that external funding requirement comes in our budget.
Yeah, and you mentioned the board. You're a part of this board, or if I remember right. Can you give me examples of what kind of initiative can be funded with the fund that you fundraise? Like,
yeah, so our youth clinic is probably the biggest one. So we are the only youth clinic on the Saanich Peninsula for our area. Service youth up to the age of 25. We try to have a youth counselor. We have a physician. We have a bunch of peer support workers. We do a lot of birth and bleeding control, mental health. That's all mostly funded. Physicians do get a sessional through, I think, child and youth mental health, but the rest of the operations is funded with donations. And our community is very supportive of our youth clinic. Anytime we're doing a fundraiser to support that, we get very big contribution and support from our community. So we're very happy about that.
And if you can summarize what really works well versus the challenges that your clinic is facing, what are the two top things that working super well, and what are the other two things that are being really challenged still today?
Yeah, I mean, I think what works well is we tend to have regular operational leadership meetings. So if there is a challenge or something we're working through, we talk it out and just make decisions as a group. A lot of the operational decisions are made by the operations team, which is good. I think it builds trust. And I think one thing we do really well is our culture. We have a very supportive educational and mentoring environment. People are trusted to do their job and do it well. And so within their role and scope, people are trusted to make decisions, but seek feedback and mentorship when they need it. And I think we also always learn from our mistakes and then do it better the next time.
Awesome. And if you were to start Shoreline again today, what would you do differently?
That's a tough one because we were, I think, the first in the country to develop a nonprofit organization to run primary care. And we have learned a lot along the way. I think one of the things is maybe more clarity, knowing what we know now. Of course, it was hard at the time, but when onboarding new people to the team, a bit more clarity around expectations, more clarity around what the organization is and how it's different, and really outlining that clinical versus operational autonomy. Because I think with the size of organization that we are, there's some give and take around. Physicians are used to having a lot of autonomy. And in order to be efficient and effective in an organization as large as ours, we have to standardize operational workflows and processes. And I think just making sure that everybody knows up front the expectations around that and that they know what they're signing up for.
I find it very interesting, and definitely it's a good model, just to see the size of the clinic and the reach that you have and how much you're really helping the community is commendable. I have a personal question to ask you. You're a physician, you chose to help build and lead a clinic rather than joining a well-established one as a practicing physician. What led you to that decision?
I mean, I think I had the opportunity of seeing how the Sydney clinic was going. So that's one thing. When I came to this community, I was running my own clinic, and I like to be in control. I like to do things my way, and I was, running my clinic. Had a bit of hesitancy, honestly, to join a clinic like this up front because I didn't know what kind of autonomy was going to be taken away. And I have a lot of big ideas around efficiency and innovation and creativity and how I wanted to do things. But then seeing how the clinic ran, and then also just thinking about the opportunity if I was to join this organization, what we could do. I think that's why I decided to join. So kind of seeing their success, and then also seeing the potential for me to really get the support to be able to continue to thrive and grow within this career.
This is definitely courageous, and kudos on that. What do you think most physicians underestimate about running a clinic in BC?
I don't know if they underestimate it or if they know and that's why they don't want to do it. But I think the biggest things probably are the finances, like balancing budgets. We don't learn anything about running a business from like budgeting and operational finances perspective. So that's huge. The other big piece is the HR challenges. Hiring staff, firing staff, having to deal with, HR conflict, those types of things. Again, we're not trained to do it, nor do we have the time to do it. So that's another thing that I often hear is a big burden, and I'm very grateful for in our organization that we have support and resource around that. And then as small as it may seem, I think the IT challenges that we deal with in terms of like our EMR, printers not printing, all these things that take time out of the physician day when they're running their own office.
Definitely. And from a day-to-day leadership perspective, can you describe what a typical week looks like for you?
Yeah. So in general, my typical week is I do a combination of office, administrative leadership, and following my own patients in hospital. So I have Mondays and Thursdays I set aside for administrative and leadership activities within my hospital leadership role and my medical director role at Shoreline. And also try to set aside some time for my own well-being in those days. And then Tuesday, Wednesday, Friday, I'm in the clinic doing visits, primary care visits in our clinic. And then if I have a patient that gets admitted to hospital, I would see them usually first thing in the morning, if not at lunch or at the end of the day, if they came later in the day. And then also long-term care visits usually would be on my Mondays or Thursdays. And then once in a while, every 8 weeks or so, I try to keep it to that cadence. I do a week of inpatient care at our community hospital as well.
Also, we know that as a physician, you guys have a lot of administrative to do. So personally speaking, how do you balance this administrative responsibility with clinical care?
I think time blocking the schedule has been really important for me. And I used to say, I have Monday off. Well, I've definitely reframed my thinking around that. Like Monday is not a day off. It's not an office day, but I definitely have a lot of things to do. I feel very fortunate that we have funding for sort of leadership and coaching in BC through our joint collaborative committees. And I've had the opportunity to do some personal, professional coaching for my leadership, as well as I have two colleagues in Victoria, Alicia Power and Sarah Lee, who run a program called Empowered Time. And I've taken that course as well, which has given me some strategies for priority management, things like color coding my calendar, time blocking things in to make sure I get them done, forecasting at the beginning of the week, kind of setting aside time to look at the entire week and managing the week in terms of my energy budget and time.
And what keeps you awake at night as a leader in primary care?
Oh, well, one of the big things for me in one of my passions, the thing I did my quality improvement project on, would be access to primary care and our emergency rooms overflowing with visits for non-urgent things or things that don't need to be dealt with in the emergency room. So in our community, for example, 40% of those visits for non-urgent visits are patients who have a family physician. So I did a quality improvement project trying to redirect those patients to the clinic for those visits, same day or next day access. And then now I'm trying to spread that project through divisions of family practice and some other avenues to other communities and other clinics in BC.
And you mentioned mentoring new physicians or a leader. What do you think, like, what are the top two things that they struggle with that you think, like, you repeat yourself every time you meet a different person, a physician or a leader in a clinic? What's come across more often?
I think the time management is one of the biggest things. Yeah, the demand on our time and the constant need to feel like you're doing more and more. And then with that, I think comes the struggle of boundaries and actually learning how to set boundaries and learning how to say no to protect yourself so that you can continue to do everything that you're doing and not burn out.
And if you are to put words on the core values of your practice and yourself as a person that drive and guide your decision, what those values would be?
Collaboration, well-being, authenticity and justice are very important to me. And then connection. And if I get one more, creativity. That's sort of creativity and innovation.
I really love that. And you mentioned hiring and firing. So what do you look for beyond clinical competence when you're hiring?
Fit, I think. Like one of the secret sauce, I think, of Shoreline is our culture and our fit of everybody that works together and everybody who really, I think, believes in what we're doing. So we really try to assess the values of the individual we're hiring and whether or not we feel they'll be a good fit in the organization.
And personally speaking, your connection with the medicine, what moment in your career really reaffirmed why you choose medicine? Is there like a aha moment that made you, okay, this is why I choose it?
I don't think I have one moment per se. I feel very fortunate that I actually, like, day to day, I do live this. I feel like I've found a good balance of all the things that I truly love doing. And yeah, there's certainly patient experiences where you really feel this. You know, if you carry somebody through, you know, you're following in the clinic, they get sicker, you admit them to hospital, you transition to palliative care, you support the family, you then support the family after they pass. I think it's those kind of moments and progressions for me that I realize that that family medicine and that longitudinal relationship and that trust and connection that we have with patients is so meaningful and really what for me is protective against burnout and provides me, I think, that sustainability in this career is it's just so meaningful for me.
Mm-hmm, definitely. And it's definitely a system that is under constant pressure. And from your perspective, how do you define high quality care in a system that is under constant pressure?
This is hard. I think I do fall back on the quintuple aim. We talk about the quintuple aim a lot in BC. I don't know about the other provinces, but just that sort of patient experience, population health, provider experience, equity, and then the per capita cost of the system. So I think trying to keep that in mind. And also BC health quality has a good matrix on healthcare quality as well, and the dimensions of quality, which include, like, you know, the individual perspective, things like respect, safety, accessibility, appropriateness, effectiveness, but then also that system level lens on equity and efficiency in the system. So it's hard because we are under constant pressure, and I think we have to just try to fall back on thinking about those quality matrices and trying to continue to advance where we can within the domains.
Also, in 2024, you received a teaching award. So congrats on this well-deserved recognition. As leaders, we often focus so much on guiding and supporting that we don't always take time to pause to really see the real impact we have around us. So is there a moment where during your teaching journey that made you realize the impact you were having on your students?
Yeah, actually. And I wonder if it was this student that ended up nominating me. And getting that award and reading through the nomination was incredibly impactful. But I take second year medical students, and they come for like 3 hours in an afternoon for 8 weeks in a row. And at the end of the rotation, he was just so excited and looked at me and just said, like, thank you. Like, I didn't realize family medicine was so awesome. Like, this was the best rotation yet in my medical school. So that it was, it really made me pause and think, like, I am making a difference to these second year medical students who this is maybe their first exposure to family medicine.
Great. Let me ask you the difficult question. As a physician, it means spending your entire day caring for a sick patient and spending the time with them, and could be very draining. Has being a physician changed the way you see people?
Probably, because we have access into them, in their most vulnerable times. So I think I see people as more vulnerable for sure. And I see people as more fragile sometimes, just realizing, like, sometimes when you look at the whole person and everything that people are dealing with, and then that's, one little snapshot in a 15-minute visit that they have in the clinic, but trying to, over the last 10 years, I've gotten to know my patients quite well. And so I think just seeing them more for the whole person and how everything impacts them. I think in the beginning, I used to get quite frustrated or really drained and exhausted when people came in with a lot of problems, maybe thinking that I had to fix them all. But over time, I've learned that sometimes they just want an ear and they just want to have the opportunity to talk through it. And I don't necessarily have to have an answer at the end of it.
Is there a particular clinical situation that you find most emotionally demanding?
Probably just along the same vein, when people are really struggling and I can't fix it. So things like chronic pain, where we've done a lot of investigations, a lot of different treatments, and they're still really struggling and it's really impacting their function. Or really difficult and complex mental health, where people also have a lot of other social stressors or the social determinants of health that really, if those were addressed, things would be so much better for them. And that's frustrating as a provider, because sometimes I feel like I don't have the tools to be able to do my job in this system.
And what keeps you motivated on difficult days?
I think no matter how hard an encounter can be, overwhelmingly, the day is positive. And I get a lot of gratitude from my patients, and the longitudinal relationship that I've built with my patients. I just get so much meaning and value from every interaction, that if there are a couple of really draining ones, I do find I can recover.
And is there anything else you do to protect your mental health?
Yeah, I do. So in addition to like some of the coaching and values work that I've done, one of my other lovely colleagues, Mark Sherman, runs mindfulness meditation retreats for healthcare providers. So I try to do that once a year. So the last 3 years, I've gone to 5-day retreats on Salt Spring Island or Cortez, just to give myself the time and space to come back to the values and what's important and get away from the busyness.
Yeah, it's a way to balance it out, right?
Mm-hmm.
According to a 2025 National Physician Health Survey from the CMA, more than 46% of physicians report high levels of burnout. So we are going to talk about it. Have you ever personally come close to burnout or maybe did a burnout? And if so, what helped you restore balance?
If I came close to the sort of moderate to severe burnout, but there's a time after I had both my kids coming back and just trying to balance it all, feeling a bit of overwhelm. And I remember doing one of those well-being surveys and kind of thinking, I wasn't getting as much meaning and value from my work, or I wasn't kind of just not caring as much as I should or used to. And that's when I accessed the coaching. And through BC, there's also the physician health program. So you can access individual counseling, you can do the coaching and mentorship. So that was my first experience with it, and then went on to do another year-long coaching program. And one of the biggest pieces with that was looking at values. So the questions that you asked about values, I have answers because I did that work, which is neat. And so what I found at that time was that I wasn't living in line with my values. I was working too much. I was missing bedtime or dinner with my kids. I was doing things that this is what I say my value is, but then I wasn't behaving in line with my values. And so doing that work allowed me to shift and prioritize and change things. I quit doing emergency medicine at that time, so that I could prioritize the things that were important to me. And then I think as human beings, when we're living in line with our values, we're much more likely to not burn out, and we're more likely to have sustainability in our career.
Definitely. Yeah, I like it. It really sounds like, and I'm happy for you that it really feels like you're living your authentic life, following your value. And also, what boundaries have you learned to set? And we talked a little bit about it earlier in the podcast, either with patients or with the system.
I'm still not the best at boundaries, I will say that. But I think kind of in line with my values and some of the goals I set for myself. So like one of them was I wanted to have dinner with my kids, like at least 5 out of 7 nights. And so setting that sort of rule or boundary for myself so that I would say no to meetings that were outside of that goal or boundary. And same with my schedule, I try to not add too much. I try to block wellness time so that if it's blocked in my schedule that I'm going for a hike with my friend or I'm getting a massage or getting my hair cut, then I'm not going to book a meeting at that time. So really trying to schedule those wellness things far in advance helps me to say no to other things. But it is hard because the system needs us and we're constantly being asked to do more. So it is hard to say no when we're called to this profession to help and do more. It is hard to say no when you're being called from all angles to do more.
And I have a question here, and like I hear sometimes from physicians that the new generation of physicians think differently when they approach the profession and the boundary setting. Do you think it's a myth or it's reality?
I think it's reality. I think that we've really swung in terms of like the culture and the mentality in this profession where, my grandfather, who was the reason I went into medicine was their life, right? They were never home for their family. They lived, ate, and breathed medicine. And it was to an expense of their mental health, their marriages, their family life, and then now I feel like it has swung a little bit too far where people kind of feel like they want the 9 to 5. They don't want to have the extra responsibility. They don't want to be on call. We've lost a lot of physicians from hospital work. So it's hard. We need to respect the wellness and the work-life integration in a sustainable way, but also we're an essential service and we go into this profession to help people. So
should we worry about that? About this dynamic?
I think if we start to address it and change the culture, it's going to be okay. which I think we are. I think we're recognizing it in residencies in medical school now that, there was a bit of a overwork culture in medicine for sure.
Yeah. And do you think, like, we hear a lot of people saying that the healthcare system in Canada is broken? Do you think that's the sort of that? First, do you agree with it, with that statement, or you think it's just misalignment, and whether this is really contributing to the dynamic that you just mentioned a couple of seconds ago?
Oh, it's hard. I don't think it's broken. I think that there are definitely gaps. There's gaps in access, there's gaps in equity and sustainability. And I think we need to optimize it. We do give very good care to Canadians when they get care, but I think that there is this gap of access where sometimes people wait way too long for care. And then it costs the system a lot of money. And I think, especially through COVID and post-COVID, we contributed to this culture of people not wanting to work as much because we burnt them out, right? If you show up at a hospital and you're understaffed and your lists are twice as long as they should be, and people walk away, they don't want to do that work. So I think we're in a transition now where we need to look at efficiencies and sustainability and how can we work smarter, not harder, to be able to help address some of these gaps in our system and not burn out the healthcare providers.
Anything changed in the care since you started being a physician till today? Did you see any major shifts or changes in the system? And I'm going to ask the same question about if you noticed any change in the complexity of care of patients.
Yeah, so I mean, in the 10 years that I've been practicing, I've certainly seen a shift in respect and value for primary care, for family physicians, really acknowledging the work that family physicians do and respecting that and valuing it. We've seen that with our payment model in BC. I think there's a lot of advocacy in BC. Like in the last 10 years, I've seen more advocacy through like BC Family Doctors and other organizations that are really working to advocate for primary care. I've seen a shift in the learner's perspective in terms of they are now medical students and residents like wanting to do family medicine again, which is good. I've definitely seen a change in complexity, and it's hard to know how much of that is because our EMRs have gotten so much better. So we just like know so much more about our patients now and have access to so much more data and investigations and even just information, literature access and stuff like that, that we feel like everything's way more complex, or if people are truly getting more complex. I think in my area, they are getting more complex because they're really old. We have a very aging demographic, and a lot of our patients have multiple comorbidities that we're managing, like internal medicine.
And definitely, and you mentioned it a little earlier, the LFP model. It was a major shift in BC. For listeners who may not be familiar with it, can you briefly explain what the model is?
Sure. Yeah. So when I first started, we were doing like traditional fee for service, just a la carte. You submitted a billing code for work that you did. And then a couple of years ago, BC Family Doctors did a lot of work with advocating for this longitudinal family physician model. So if you have a practice in BC and you're doing longitudinal primary care and you have a panel, you can sign up for it. And there's 3 components. There's still a like per visit code that you can submit. So there is some remuneration for the number of patients that you see, but it's not the main thing. There is a time-based billing that runs in the background now. So per hour, you get an hourly rate for either direct care or indirect care. And so that indirect care now pays us to do all the unpaid work we were doing before, all the tasks, looking at labs and imaging and writing consults and completing our notes at 10 p.m. and all those kind of things. We actually get paid for that now, phoning family members, doing family conferences, all that type of stuff. We get paid on indirect care now. And then the third component is a panel size and complexity bonus. So every quarter you get an additional payment for the size and complexity of your patient panel.
Yeah. And how has it impacted your clinic and the physicians working within it?
I've seen a big shift in like wellness of the physicians. Feeling valued makes a big difference. If you feel valued for the work that you're doing, you're not so resentful about doing the work. So it's made things a lot more sustainable. It stopped a lot of physicians from quitting practice. It's allowed a lot of physicians to join. We've had, since the payment model, thousands of people join the model. So it has had a big impact. For our organization, financially, it's had a huge impact. I think on average, it was about a 40% lift in gross billings. So that's huge. And at a time when inflation really kicked up as well, we would have been in real trouble if it wasn't for LFP, because before we were paying about 30 to 35% of our income. That probably would have gone up to 40 to 40%, 45% of our income if it wasn't for LFP, because everything got more expensive in the couple years following COVID. And because of LFP, that even with that 40% lift, the overhead is still kind of 28 to 32%, but much more sustainable because we're getting paid more.
Yeah, I have to say it's commendable what the province has been able to achieve with this model, and whether the health minister or doctor of BC or the physician that participated in putting this together should be super proud of what have been achieved with that. We see something different in other provinces where we see the opposite of valuing the physician. I really hope some of those folks would listen to our podcast and be inspired by that. But well, kudos for that, for sure.
And if you had to pick the biggest pain point right now, getting access, navigating referrals, wait time, specialist shortage, or something else, what would it be? And what's a practical fix that could actually help, according to you?
Yeah, so I think access in general, like as a broad bucket, it's going to be access. And in BC, what I saw was the ministry just put all their eggs in the attachment basket. So all the new to practice contracts had big attachment targets. With LFP, the main thing they were looking at was attachment. And with too much attachment comes a lack of access. So I think that that's one of the biggest pieces across the board: access to primary care, access to specialists times, access to surgery, access to cancer care. So, I mean, on a small scale, I think something like the quality improvement project I did, just encouraging clinics to see their own patients in the clinic. So if they're attached to your clinic, really prioritizing advanced access for same day, next day visits to keep them out of a merge. I think that's a very practical thing that could have a huge impact if it was scaled. And then I do wonder about, like, particularly around cancer care, we know that access to early care and intervening on a stage 1 cancer is way less expensive than, stage 4. So I do wonder if, as a country, if you can't meet the time metric within your province, paying for it to be done in the next province so that we can still get the care to the patient in that stage 1 phase. And kind of having more flexibility across provinces for doing that.
Do you think some provinces are more equipped to do this kind of those screening earlier in the stages to meet those metrics?
I think so, but I don't know. The government surely has data on what's acceptable and what's not in terms of our cancer care wait times, and we don't really see it. And I don't know which provinces are meeting it and which provinces aren't. But, here, being so close to Seattle, we see people go to the States. Yeah.
So we've learned a lot about you, your clinic, what drives you, and what matters most. Now let's dream a little. When you look ahead, what gives you most hope for the future of primary care in BC?
Well, I think that we are valuing family medicine and primary care gives me hope. The fact that medical students and residents are now saying like, wow, family medicine is so cool. And I, want to go into family medicine, and they're feeling like they're properly remunerated for the work. That gives me hope. In BC, the big push towards team-based care gives me hope, because if we integrate it well, there's huge potential impact there. We just don't have enough family physicians and nurse practitioners to take care of everybody. And I think if we move away from the physician-centric model and really allow team members to work to their full scope, we can serve a population with less physicians if we're truly working to full scope. So integrating team-based care has been very successful at Shoreline, and I think it gives me hope for the future of primary care. What else? I think, in BC, we're starting to talk about community-led clinics and funding communities to design and govern these community-led clinics at the local level, which I think is going to be the success. Put the money down at the local level, get municipalities involved to help how they can, to support each local community and what they need.
That's interesting, because the team care based model is already innovative in Canada, and hearing you talking about the next innovative step, it's really inspiring. And what's been your experience or impression of AI in healthcare so far? Do you see it as a must-have, a nice-to-have, or mostly irrelevant? And what would make you say that?
I think it's a must-have now and going into the future. Where I'm personally using it right now is AI Scribe. And it's made a big difference just in terms, again, of my administrative burden, I have more time to have dinner and spend time with my children in the evenings now that I'm not spending time trying to remember what I talked about that day. So the AI Scribe has been huge. And that's what I've been hearing across the board from my colleagues, is that it just allows you to look at the patient, have that connection. You can listen for values in the conversation rather than listen for details, because the details are being captured. So I think where the must-have piece, like we talked about earlier, with just so much information coming at us and the advancement of EMRs, it's that AI integration to be able to mine things from our EMR and kind of do the administrative stuff for us, so that we don't have to, and so that we provide better care, because we do have so much information coming at us, and we're human, and we're going to forget, I forgot to talk to them about their Prevnar vaccine, or I forgot to remind them about their mammogram, or whatever. If we have AI doing some of that stuff in our EMR, I think it will be really helpful. And just generating the lab rec as we're talking, generating the imaging rec, all these things that I know you guys are thinking about and talking about already. So I think that's huge. I do have a little bit of concern around AI thinking for us and coming up with, the plan, and a little bit of concern around our next generation of learners. If they're allowed to use AI in their training, are they going to develop the necessary critical thinking skills and, the connection to the patient? I have some questions and concerns around that, but from like the administrative burden piece, I think it's a must-have for sure.
Well, thanks a lot for sharing your thoughts, Dr. Bourdon. And yes, we think AI is going to be transformative. And what we understood from the market is when it's back end, like solve like administrative tasks and filling forms and scanning documents and managing some tasks, it will be adopted super quickly. But the moment it's going to start communicating with the outside of the clinic, with the patients, and the reasoning part, I think, without a safety net and a lot of transparency and ethics of the AI, adoption would be slower. And seeing physician taking it a bit slowly there. So let's imagine you wake up tomorrow as the Minister of Health. What is the first and most important thing you would do?
Well, I mean, acknowledging that I have a lot of ignorance when it comes to politics and government, and I have a very narrow lens on the primary care piece. I think, I think prioritizing Canadian grads who have trained abroad, I think that needs to be one of the big things we focus on, is get the thousands of Canadians that have done medical school elsewhere back in Canada practicing medicine where they want to practice. I think that's a big one. And trying to find a way to fund the capital infrastructure and the operational costs for primary care, because like we are the only essential service that has to fund our own infrastructure. And when you think about that, it's crazy. Like if you asked the firefighters to put 30% of their salary aside to operate their fire hall and their trucks, like it's crazy making. So I think that infrastructure piece, and as grateful as I am for a supportive community that continues to support us in our fundraising efforts, we shouldn't have to ask the community to fundraise and, pay for some of these pieces to run primary care. In a system that's public, primary care is kind of a private sector. Except then we can't actually adjust our profit margin or our revenue to make the business work. So it's interesting. And I think we either need, this is a huge can of worms that we won't get into, but we either need to look at, learn from other countries and how they're doing a hybrid model of public versus private, or really fund the public system properly so that the infrastructure isn't being funded by the physicians.
Yeah. We have access, like we're deployed in many provinces, and we saw a lot of type of we are also deployed in Latin America. We saw super private practice, and in some instances we see fully public funded setups. Like I said, it's a warmer can. I think it changes a bit the behavior, and there's the autonomy aspect of the practice, the medical practice, and the physician, how she or he want to operate. But I fully agree with you. It's one of the rare professions where you have to fund the operational infrastructure. Mm-hmm. And if you could speak directly to policymaker or health system leaders, what would you want them to understand?
I don't know. Like, again, I guess it's that question of like, are there some policies we could change around that interprovincial care and access to care when people need it in a less siloed way? Maybe I don't know enough about government policy to know what's sort of a barrier or obstructing that. But I think if we could look more at evidence based timelines and when people should be getting access, and then implement some policy or solution around making sure we meet those metrics, that might be helpful. And then I do wonder as well, as a country, like seems to be a lot of bureaucracy, and with that bureaucracy, the siloing, and we have 11 different ministries of health. We've got, even within BC, 6 different health authorities. So you wonder what inefficiencies come with the bureaucracy and siloing of healthcare.
Yeah, I think you're right on point, Dr. Bourdon. Any takeaways or key messages that you would love to leave for physicians across Canada today?
I think I've talked a lot about it already, but just stressing the fact that I obviously believe that primary care is our backbone of our healthcare system, and addressing, preventative health, social determinants of health, and making sure that we do primary care really well, I think is what's going to lead to the success of our healthcare system overall. So making sure that we value that and support that in the decisions that we make moving forward.
And before we close, what legacy do you hope to leave through your work?
Oh, I don't know. I don't really expect to leave a legacy.
You're a truly inspiring leader, and everything. Like I was hearing you across the podcast, from how you started, your value, your ethic, and just your comment there. I'm sure you're not doing it for the money. Like, you're doing it for something bigger than than financial or whatever. You're working in a non-for-profit, you're working hard, you're barely putting barriers between work and family, and you're still on top of your thing. So I'm pretty sure you're doing it for something bigger than that.
Yeah, I mean, I think, have you heard of the Japanese concept, the ikigai? It is like the concept of meaning, like a reason for being or your joy of living. And the ikigai sort of combines what's important to you, what you love, what the world needs, what's important to you, and what you make money doing, and the sort of where all those Venn diagrams are the ikigai. Awesome. And I truly believe that medicine is my ikigai, that this career and the wide range of things that I can do within it are my ikigai. And I feel very grateful for that. So I guess, like, in terms of my legacy, I do love teaching. And, you know, I've had 6 or 7 residents come through, most of which have stayed, lots of medical students. And so I think that if I can inspire the next generation of medical professionals to be able to find what they love to do so that they can have a long, sustainable career in medicine, then that would be success to me.
I think that's a wonderful way to wrap up our podcast. So, Dr. Sienna, thank you very, very much for your time and for sharing your story and your thoughts. It was truly inspiring, and it definitely left a lot of meaningful insight to our audience. I wish you every going success for you and for the Shoreline Medical team. Thank you so much.
Thank you. Thanks for having me.
Pleasure.
Thank you.
Thank you, everyone, for tuning in. I'm sure Dr. Bourdon's journey and vision has inspired you. We'll include the details of what we discussed today in the show notes. Please share the episode with your colleagues, family, and friends. And with that, we'll see you at our next Primary Care Reimagination.